So this talk is challenging, having had listened to Dr. Jabu's impassioned presentation on when to monitor and what to do. So I think I might as well finish the talk and we can move on to the next talk. But since I'm here, I will give my best, do my best and see what we can conclude or not conclude after this session. So I think everyone in this audience has witnessed, a marked improvement in the management of CML over the decades. And we have better drugs now. There are second-generation TKIs, which are more potent than imatinib. By and large, these drugs have a good safety profile, although we do know there are treatment-emergent adverse events, and physicians like yourself are now more experienced with the use of these second-generation TKIs. And what's also important is that there is better monitoring. Okay, we have peripheral blood quantitative PCR for BCR-ABL quantification. This is less invasive than bone marrow cytogenetics, and this allows us to perform more frequent monitoring. And there's also an ongoing effort to standardize the BCR-ABL measurement, and this allows labs that have been standardized to report with certain level of confidence results which are similar to another lab which has also been standardized. It's becoming increasingly accessible. I realize that this may not be available in all your centers, but with the introduction of, for example, the Cepheid platform, this is increasingly becoming more accessible. So again, European Leukemia Net, in its recommendations last year, they recommended that monitoring should be done. Cytogenetics should be done from the bone marrow at 3, 6, and 12 months. And once CCYR is reached, that can be done every 6 months. So every 12 months. And for molecular monitoring, it should be done every 3 months until MMR is reached. And once MMR is reached, it can be done between 3 to 6 months. So with all these monitoring results, what can we do with these results? Do we act on them, or do we sit and wait? So there are 2 guidelines. The ELN came out with its 3rd edition in 2013, last year, and the responses are categorized into 3 categories. One's optimal, one's warning, and the 3rd one is failure. I'll go through this table in more details later. The NCCN also this year came out with a set of guidelines, a bit easier. They had just 2 categories, optimal and failure. So what do these 2 guidelines do? And I'll walk you through the guidelines and give some evidence as to how these guidelines were derived. So importantly, in the ELN 2013 recommendations, they recommended that patients who are in the failure category should receive a different treatment to limit the risk of progression and death. Those in the warning category will require more monitoring to permit timely changes in therapy in case of treatment failure. Okay, so I think most of you in the audience, maybe not all, would agree that if at any time, if there's a loss of complete hematologic response, if there's a loss of complete cytogenetic response, if there's a confirmed loss of MMR, mutations, BCR-ABL kinase domain mutations, Philadelphia positive clone evolutions, these would be triggers to switch therapy, and these would be, according to ELN guidelines, a failure to first-line therapy. But when do we switch? Do we switch at 12 months? And this data from the Hammersmith group, as well as other groups as well, what they've done and they've shown is that failure to achieve a complete cytogenetic remission by 12 months puts patients at risk of progression or death. And so both the ELN and NCCN recognizes this, and the inability to achieve CCYR, or Philadelphia positive metaphases of 0%, or BCR-ABL transcript level of more than 1% would be considered as a failure to treatment. The ELN also recognizes the lack of achieving MMR as a warning. Should we switch earlier at 6 months, for example? Again, this is data from the IRIS study, and what they have shown is that failure to achieve a major cytogenetic response by 6 months predicts for worse outcomes. Patients have lower event-free survival, and a lower chance of achieving a CCYR. And this is data from the German study group, and they also showed that in patients who do not achieve a major cytogenetic response by 6 months have a lower 5-year overall survival. In addition, they've also shown that at 6 months, if patients do not achieve a BCR-ABL level of less than 10%, this also confers a poorer overall survival at 5 years. So again, both the ELN and NCCN recognizes this, that failure to achieve major cytogenetic response at 6 months or a BCR-ABL level of less than 10% is a failure to treatment, and patients may require a switch of therapy. And the Hammersmith group in 2012 also, in the analysis of their patients, found that patients who do not achieve a BCR-ABL level of 1.67% or lower had a poorer 8-year overall survival, poorer 8-year progression-free survival, and a poorer event-free survival. And this was confirmed by the German group, which also showed that 1% at 6 months was an important level to reach. So in recognition of this data, the ELN has recommended that this would be a warning. So patients who do not achieve less than 1% at BCR-ABL require more frequent monitoring and may need a change of therapy. How about earlier? Should we switch at 3 months? Again, the group from Hammersmith shown that if the patients do not achieve 9.84, which is, I think this is using some calculation, if you do not achieve a level of 9.84 or less, this confers poorer 5-year overall survival, so 8-year, poorer 8-year progression-free survival and event-free survival. And again, the Germans as well, failure to achieve a BCR-ABL level of less than 10% predicts for poorer 5-year outcomes. And again, this data has been confirmed in both the decision and the INSND data when dasatinib or imatinib was used as frontline. And again, in the Germans, they also showed that failure to achieve a major cytogenetic response by 3 months tend to predict worse outcomes in terms of 5-year overall survival, 5-year progression-free survival. So what does ELN and NCCN recommend at 3 months? So there's some slight difference. The NCCN deems the lack of a major cytogenetic response, failure to achieve a BCR-ABL levels of less than 10% as failure, but the ELN says it's a warning sign, may not necessarily need a change of therapy. So should we switch treatment for all poor responders at 3 months? I think there is some hesitancy, of switching at 3. Should we wait till 6 months? So the 6-month response add additional useful information. So the Hammersmith data, the Hammersmith Hospital stated that additional measurement of transcript levels at 6 months adds very little useful clinical information to a 3-month result. Whereas the MD Anderson stated that assessing response at 6 months may provide a better predictor. So last year at the ASH 2013, there were 2 important presentations, one from the Adelaide group and one from the Germans. And the Adelaide group state that any BCR-ABL reduction below 10% at 6 months significantly improves the outcome of CML patients with a poor response at 3 months. So what they showed was that, indeed, in their cohort, 3-month BCR-ABL level of more than 10% is predictive of outcomes. Okay, so the 4-year overall survival was significantly poorer in patients who had more than 10% at 3 months. They also had poorer progression-free survival and poorer failure-free survival. Okay, but when they looked at the patients who had 10% at 3 months, and these patients were followed on to 6 months, what they found was that patients who did achieve levels of less than 10% had better overall survival than those who remain more than 10% at 6 months. And in fact, the outcomes, if patients had achieved less than 10% at 6 months, seem to be as similar to those who achieved 10% or less at 3 months. So they next asked, does the rate of reduction of BCR-ABL levels have an impact on clinical outcomes? So what they did was to take the BCR-ABL levels of the patients who were 10% at 3 months, took the baseline level before treatment, and compared the levels at 3 months. And what they did was to measure the rate of the reduction by the number of days over which the BCR-ABL level was halved. So this was halving time. So what they showed was that, what they found was that 79 patients had a halving time of less than 90 days, and 19 patients had a halving time of more than 90 days. And they found that halving time at 3 months is predictive of outcome. So in patients who had halving time of less than 90 days, the overall survival, progression-free survival, and failure-free survival were significantly better than those with halving time of more than 90 days. And again, the German group also showed that the exact decline of BCR-ABL transcript levels seemed to give a better prediction of outcome. And this is what they showed, was that if the ratio of 3-month BCR-ABL to baseline BCR-ABL was less than 3.5 times, this again conferred a better overall survival and progression-free survival. So I think in conclusion, we agree that 3-month BCR-ABL is, okay, you may agree that 3-month BCR-ABL more than 10% is the poor risk, but not all patients have a poor clinical outcome. So this should still remain a warning sign, not a failure. And I think the rate of reduction over the first 3 months is important. So for example, if a patient has a halving time of less than 90 days, or less than 3.54, the patient could remain on first-line treatment, or imatinib, or a second-generation TKI. But if a patient has a halving time of more than 90 days, then this patient could be deemed a failure, and a switch of treatment may be required. And in patients whom you continue for another 3 months of treatment, then at 6 months, if patient still remains more than 10%, then these patients would be deemed failures, and I think a switch of treatment would be required. So with that, I thank you for your attention, and we'll take questions later.